Good afternoon, everyone. I'm Dr. Guy Mintz, former president of NELA, and I'm very happy to present today's Practical Pearl discussion. We're fortunate today to have Dr. Nick Marston with us presenting this topic. He is a preventive cardiologist and lipidologist at Brigham and Women's Hospital. He's part of the TIMI investigator group. He's been a leader in the field of lipids, and particularly a leader in the field of triglycerides, including ApoC3, angiopoietin-like protein 3 and 4. We're going to hear more about that later today. Um, he has always been one of our stars, and very happy to have him this afternoon presenting practical pearls on novel therapeutic targets in hypertriglyceridemia with a focus on ApoC3, angiopoietin-like protein 3 and 4. So without further ado, I'll introduce Dr. Marston. This is not a CME program today. This is for your general knowledge, and everybody will leave brighter and smarter by the end of today's discussion. So, Dr. Marston, take it away.
Well, thank you, Guy, and thanks everyone for attending today. We'll go through this topic. There's a lot to cover. It's actually a very exciting space. The last year or two, we've had a lot of major trials, publications, new drugs in this space. So a lot to cover, and we'll leave some time for questions at the end, which Guy will help to moderate. So let's go ahead and dive in. I'll start here just with my disclosures. I'm an investigator at the TIMI study group, so we do a lot of clinical trials, especially those in the lipid lowering space, including some of these targets and drugs that we'll be talking about today. But I thought it best to start with a case, as NLA is very clinically focused, great group of lipidologists, and I wanted to present a case of a patient that I've been seeing for the last few years now. She came to me as a 45-year-old woman with severe hypertriglyceridemia. And her history is quite interesting. She was actually diagnosed with hypertriglyceridemia at the age of just 3 years old. She was found to have lipemic blood on lab work and also xanthomas on the skin. Her triglycerides were almost always above 1,000 milligrams per deciliter and even as high as 10,000 milligrams per deciliter before she got on therapy. She was started at age 10 on gemfibrozol, later then switched to fenofibrate, atorvastatin, niacin, and fish oil for many years. So essentially on kind of quadruple therapy for TG lowering. But all of these had little effect on her triglyceride levels. Here's her course kind of through adulthood from age 30 to 45. So this is a 15-year course leading up to the time I met her. You could see again, this is plotting her triglycerides over time. And she was over 2,000s many of the time, almost always over 1,000. Really, the lowest was about 500. So very clearly, very severe hypertriglyceridemia here. You can see the therapies that she's on, but most notably in the 5 years before I met her, she started to have bouts of acute pancreatitis and actually had four in the 5 years before I saw her, including an episode of necrotizing pancreatitis, which prompted the referral to me in the lipid clinic. Here's the CT just showing her inflamed and necrotic pancreas on that last hospitalization. Her TGs were 1,800 milligrams per deciliter at that time. So she was referred to our lipid genetics clinic, and I saw her. I won't go into too many of the details here, but you can see her medication list. She was on fenofibrate. She was on atorvastatin, 40 milligrams per deciliter, so high intensity statin, Lovaza, 2 grams twice daily. So three TG lowering therapies, kind of the standard of care. Her standard lipid panel, despite that, showed triglycerides of over 3,000 in the office. And then you see direct LDL, very low as expected with these patients of 12. So I want to break the talk down into three sections. So this is kind of the outline going forward. I'll start briefly by addressing the broad spectrum of hypertriglyceridemia severity and the associated risk of coronary artery disease and pancreatitis. Then I'll move to discussing the importance of lipoprotein lipase in triglyceride metabolism and the role that ANGPTL3 or angiopoietin-like 3 protein and angiopoietin-like 4 protein and ApoC3 play in TG metabolism. And then we'll finish by reviewing the many novel therapies and clinical trial data in this space and in patients really across the spectrum of hypertriglyceridemia. So before we do that, though, just make sure we're all on the same page and discuss a bit about the pathophysiology of triglycerides. Triglycerides are carried in the circulation on what are known as triglyceride-rich lipoproteins. And there's really three or four types of triglyceride-rich lipoproteins. There's VLDL, chylomicrons, IDL, and chylomicron remnants. Chylomicrons, as depicted here on the left side of the figure, are very large particles and these are released from the small intestine, often diet related, and they carry a very, very high percentage of triglycerides. VLDL particles, very low density lipoproteins, these are ApoB containing lipoproteins that are released from the liver. And their job is to transport cholesterol and triglycerides throughout the body via the bloodstream. And these are considered to be atherogenic. So when we're measuring triglycerides, we get the lipid panel with the triglyceride results back. There's really a broad range of TGs that we may see. Most commonly, patients just have kind of mild to moderate hypertriglyceridemia. This is in the 150 to 500 milligram per deciliter range. This is very common in primary practice, preventive cardiology, lipid clinic. As many as 1 out of 10 patients will have TGs in this range throughout the lifetime. The good news for these patients is they're not at risk of some of the more serious side effects or serious outcomes with hypertriglyceridemia, but there is concern for risk of coronary artery disease and the development of atherosclerosis. And that really comes from many decades of observational studies showing the significant association with triglycerides and coronary heart disease. You can see here on the panel on the left, that relationship with the white circles is quite strong and linear. As triglycerides get higher, so does the hazard or the risk of coronary heart disease. However, if you fully adjust or at least adjust for a significant number of clinical risk factors, things like obesity, diabetes, that tend to run with hypertriglyceridemia, much of that relationship or association actually goes away. And that's different from on the far right side of this plot, where we look at non-HDL cholesterol, primarily driven by LDL. There we see that the relationship with LDL or non-HDL cholesterol is very strong, and it's maintained after adjustment for several clinical risk factors. And so this has kind of always led to the question of whether triglycerides are indeed causal in coronary heart disease, or are they kind of just along for the ride, and perhaps it's more the obesity or diabetes or other comorbidities that come along with it that are driving the heart disease. So to try and get a better sense of the role of triglycerides in heart disease, we can look to genetic data. This is a Mendelian randomization study looking at HDL, triglycerides, and LDL, and the odds ratio of developing coronary heart disease. You can see for LDL at the bottom, the relationship is quite clear that LDL is causal in developing coronary heart disease. We know that well from all of the trials. Triglycerides appear to be similar in their effect, although not as confident of an estimate with wide CIs here. Ultimately, seeming that there is a relationship here between triglycerides and coronary heart disease, but it might not be the triglycerides per se, and more recent genetic data are showing that it's probably the ApoB containing particles that are driving this risk, maybe even the remnant cholesterol that's on these TG-rich lipoproteins. And then another avenue we can look for causality is from our large randomized cardiovascular outcomes trials. And so we looked at dozens of TG lowering trials across all classes, including fibrates, omega-3 fatty acids, niacins, and even statins, and did a meta-regression analysis to look at what would be the expected reduction in cardiovascular events per lowering of triglycerides, per millimole per liter of triglyceride lowering. These cardiovascular outcomes trials have been mixed. Many have been negative, some have been positive. And so if we kind of look at all the data together, what we found was that for every 1 millimole per liter lower triglycerides, which is about 89 milligrams per deciliter, there was in fact a 16% relative risk reduction. So it did appear that if you lower TGs enough, you would have some reduction in cardiovascular events based on the randomized clinical trials. I'll add a caveat that these results were in part driven by the REDUCE-IT trial. And if you remove the REDUCE-IT trial, that estimate drops to about 9% relative risk reduction per millimole per liter. Still statistically significant, but more attenuated and modest. So ultimately, overall, it appears that TGs, or at least TG-rich lipoproteins, are associated with cardiovascular disease, but perhaps not as strong as LDL, and it may be really about the ApoB and the total concentration of ApoB containing particles. So that's really what we're focused on with mild to moderate HTG, is reducing cardiovascular risk with drugs like statin, methyl. But when we get to be above 500 with our triglycerides, or even above 1,000 into the very severe HTG range, now we begin to worry about acute pancreatitis, which can be, deadly, cause hospitalizations, really impact quality of life for patients. And it's these patients at the very top of this triangle, the very severe HTG, TGs over 1,000, that have what we call chylomicronemia. And so when the triglycerides are over 1,000, often a lot of those are being carried on those very large chylomicrons that I mentioned earlier. And this is often genetically driven, at least in part. And so at the very tip of this triangle are the rare 1 or 2 per million cases of monogenic severe hypertriglyceridemia. And this is known as familial chylomicronemia syndrome. This is where a patient has a single mutation and typically has to be homozygous for that mutation to have persistently elevated TGs in the thousands. But there's also a more common group called MCS, multifactorial chylomicronemia syndrome. And these patients often have increased genetic risk with a high polygenic background of elevated TGs. Additionally, clinical components such as diabetes, obesity, alcohol could contribute. And so when you mix a genetic background, polygenic background risk with clinical factors, you get this multifactorial kind of drive to have high TGs and chylomicrons. So these patients deserve special attention, and you'll hear lipidologists say that they really reflect the one kind of medical emergency or urgency that the lipidologist is faced with, because when the TGs are this high, these patients can and are at high risk of very serious acute pancreatitis and hospitalization. So we want to lower it as quickly as possible. So what is chylomicronemia syndrome? How do you know when a patient you're seeing has that? Well, for one, the first tip-off is those very high TG levels. Anytime someone's TGs are over 1,000, you want to be thinking about chylomicronemia syndrome. And basically, this is when there's chylomicrons present in the blood, even after a 12-hour fast. Typically, chylomicrons should be cleared within about 3 to 4 hours after fasting. But if they persist and the TGs are still this high, that's a good sign that there's a backup in the triglyceride clearance machinery, and that they very well may have a genetic predisposition and an underlying driver or cause of this disease. Again, much of this is genetics, and the homozygous monogenic conditions like familial chylomicronemia syndrome are rare, 1 or 2 per million. But heterozygotes are much more common. About 15% of patients in this TG range have one variant rather than two. And then about a third of these chylomicronemia patients have polygenic risk for high TGs. And then about half remain genetically unidentified. To make the diagnosis then of chylomicronemia, you need the presence of chylomicrons plus one abnormality. And these include a number of exam findings shown here: eruptive xanthomas, lipemia retinalis, recurrent abdominal pain or acute pancreatitis, neuropsychiatric complications. Just one of these, along with chylomicronemia, is enough to diagnose this syndrome. And when we think about the risk of pancreatitis, the biggest driver for acute pancreatitis is going to be whether they've had pancreatitis in the past, and in addition, the level of the triglycerides. So here you can see patients who have never had acute pancreatitis in the past are unlikely, less likely to have pancreatitis in the future. So that's always a good sign when someone's had TGs in the thousands but hasn't had pancreatitis. However, if they have had pancreatitis, especially if it's been recent or recurrent, you can see their risk of future pancreatitis increases significantly. And with the higher TG levels above 880 or 1000, yeah, you see the highest risk of acute pancreatitis. So we really want to get these patients' TGs below 500 if we can, because that will lower their risk substantially. So what do we do for these patients when you suspect not only chylomicronemia, but FCS? Well, there's this really useful clinical FCS score, and it's especially useful now that we have therapy, which we'll get to. But if you use this score and kind of calculate it, it can give you a diagnosis, a clinical diagnosis of FCS. And so in the case of the patient I presented, they actually scored pretty off the charts here. FCS is very likely if you score 10 or higher, and our patient scored 14. This is really driven by very high TG levels starting at a young age and recurrent pancreatitis. So when patients have clinical FCS, that's really a reason to move on then to genetic testing. Genetic testing for FCS includes 5 genes shown here, but most of these, 4 out of the 5, have only been reported in a handful of families, up to 10 families. And it's really lipoprotein lipase gene that is driving 95% of these FCS diagnoses. Still very rare, 1 in a million having these LPL homozygous mutations, but a majority of FCS will have variants in lipoprotein lipase. And so for our lab, we send off a dyslipidemia panel, about 25 genes shown here on the right. And you can see that all 5 of these chylomicronemia genes are included on that panel, including lipoprotein lipase. And so here are the patient's genetic results, and you can see that indeed they have 2 variants, 2 mutations in the lipoprotein lipase gene. One is classified as clearly pathogenic, the other of uncertain significance. And they're not the same mutation, so it's not homozygous, but here what we ultimately determined was she likely had, at the very least, was heterozygote for FCS, for LPL, and possibly was a compound heterozygote if this second variant is indeed pathogenic. So she was very much acting like FCS, hence the high clinical score. And so the first key message that I want to make is that distinguishing between moderate, severe HTG, and then even taking it a step further to chylomicronemia really has a large impact on how you're going to work up these patients, and then, as we'll see, the downstream management and treatment. All right, so next I want to move to, on that note of a lipoprotein lipase mutation, I want to move to the importance of lipoprotein lipase in TG metabolism, and then the role of ANGPTL3 and ANGPTL4 and ApoC3 in that process. This is, I would say, an oversimplification of TG metabolism and the role lipoprotein lipase plays, but I think it's quite helpful to get a big picture overview. You can see here the blue cylinders are lipoprotein lipase, and these are the key players in breaking down and clearing the triglyceride-rich lipoproteins. So on the left side, we have the chylomicrons, very large lipoproteins that come from the small intestine dietary source. And on the right-hand side, we have the VLDL particles coming from the liver. And so lipoprotein lipase is responsible for hydrolyzing these TG-rich lipoproteins and clearing them, breaking them down into free fatty acids and monoglycerols, and then more dense lipoproteins like IDL, LDL, and chylomicron remnants, which are then cleared through receptors in the liver. Now, interestingly, back in 2012, there was actually a LPL gene therapy, an adenovirus vector, that was approved in the EU 4 lipoprotein lipase. This was approved for FCS. It was the first gene therapy approved in the EU. It was not approved in the US. And after 2 years, it was withdrawn due to cost and rare use. But I think this really helped set the stage and was a proof of concept to show that if we can, activate lipoprotein lipase, LPL, if we can activate TG metabolism and clearance, that these patients have much lower triglyceride levels and can do much better. And since that therapy was no longer available, it really opened the door to some of these other targets, specifically proteins that inhibited lipoprotein lipase. So they basically act as brakes to the TG clearance system. And those are ANGPTL3, ANGPTL4, and then this red circle on the lipoprotein itself, ApoC3. These became attractive targets because of their role in inhibiting lipoprotein lipase. So we'll walk through those proteins and some of the data for them. ANGPTL3 was discovered in 1999. It's produced in the liver, and it inhibits lipoprotein lipase in the fed state, so after a meal. It also inhibits endothelial lipase, so it is involved in HDL metabolism as well. And the data for ANGPTL3 loss of function mutations, kind of naturally occurring mutations, is quite interesting. If patients have one mutation or a heterozygote, they have lower LDL cholesterol and triglyceride levels compared to those who do not have these ANGPTL3 mutations. And there's actually a dose response such that if patients have two mutations, if they're homozygous for the ANGPTL3 loss of function, their LDL and triglycerides are even lower, both well below 50 milligrams per deciliter. And you'll see also HDL for the homozygotes is lower as well, just reflecting that's impact on HDL metabolism. These lower LDL and triglyceride levels then translate to a reduction in cardiovascular events. So here's a meta-analysis of a number of cohort studies, but in all, there were about 200 carriers of ANGPTL3 loss of function variants, and those individuals carried a more than 30% reduced odds of coronary heart disease. Again, making this an exciting target, not just for TG lowering, but also for cardiovascular risk reduction. ANGPTL4 was then discovered a year later. What's unique about ANGPTL4 is that its highest level of expression is actually in the adipose tissue, not the liver. It is expressed in the liver among other organs and tissues, but predominantly in the adipose tissue. It's also distinct in that it inhibits lipoprotein lipase in the fasting state. So ANGPTL3 in the fed state, ANGPTL4 in the fasting state. And so here's a look at ANGPTL activity in the fasting state. You can see here that on the far right, ANGPTL4 is inhibiting lipoprotein lipase in adipose cells, and therefore TG hydrolysis not taking place in that adipose tissue. ANGPTL3, however, is active in the fed state, and so it is not inhibiting lipoprotein lipase in the fasting state, allowing lipoprotein lipase to hydrolyze TGs in heart, muscle, and brown fat. Now, ANGPTL4 has some exciting genetic data for it as well. If we look at the E40K variant of ANGPTL4, we see a similar story. We have heterozygotes and homozygotes, and we again see a sort of dose response in the patient in the lipid levels in these individuals. So here we see non-carriers of the ANGPTL4 inactivating mutation have TGs of 132. But heterozygotes, the TGs are 115, and in homozygotes, the TGs are all the way down to 81. Similarly, with ANGPTL4, we see a favorable effect with HDL increasing from 48 up to 67. And then notably distinct from ANGPTL3, we do not see a significant difference in LDL with ANGPTL4. This lower TG level translates to a reduction in coronary artery disease odds. So whether it's one of the E40K specific mutations or the other ANGPTL4 inactivating mutations, we see about a 20 to even over 40% reduced odds in individuals who have a lower, naturally occurring lower ANGPTL4 levels. Naturally occurring low levels of ANGPTL4 isn't just good for lower risk of coronary heart disease, but it actually carries a lower risk of type 2 diabetes as well. And so here you see about a 10% lower odds of type 2 diabetes in those who have naturally occurring low ANGPTL4 levels. And beyond coronary artery disease, there's other vascular benefits. So, a nearly 20% lower odds of aortic stenosis and a 8 to 10% lower odds of heart failure and ischemic stroke. So, a very favorable profile here in terms of the types of events that are seen or perhaps protected from very low ANGPTL4 levels. And then you can't mention ANGPTL3 and ANGPTL4 without mentioning ANGPTL8 as well. This was discovered over a decade later, but it's important because it interacts with both ANGPTL3 and ANGPTL4 in the fed state. And so it binds to ANGPTL4, creating this, excuse me, this should be ANGPTL3, creating this ANGPTL3, ANGPTL8 complex. Again, this is in the fed state, and this is when ANGPTL3 does its work on lipoprotein lipase, inhibiting its hydrolysis of TG-rich lipoproteins in the heart, muscle, and brown fat. ANGPTL4 over here in green, it binds with ANGPTL8 and creates the ANGPTL4, ANGPTL8 complex, and it inhibits the ANGPTL3, ANGPTL8 complex in adipose tissue, thereby allowing lipoprotein lipase to hydrolyze TGs in the adipose tissue during the fed state. Finally, I'll finish with ApoC3. This was the kind of first these proteins over 50 years ago now in 1969. And it's secreted by the liver and the small intestine. It's found on the TG-rich lipoproteins themselves. So I showed you that red circle on the actual surface of the lipoprotein. So it's actually found on TG-rich lipoproteins like chylomicrons, VLDL, and chylomicron remnants. It inhibits lipoprotein lipase and hepatic lipase. And both of these help to decrease the hydrolysis of TGRs, which result in increased triglyceride levels. And it too is associated with coronary artery disease. So just to summarize these three targets of interest and targets that you're going to be hearing a lot more about both in this talk and moving forward. But there's some key similarities, of course. They're all lipoprotein lipase inhibitors. They also all are associated with coronary artery disease, and having low levels is protective against coronary artery disease. But here's some of the key differences. So for ANGPTL3, it also inhibits endothelial lipase. It also interacts with ANGPTL8 during the fed state. ANGPTL4 is found predominantly in adipose tissue, and it interacts with ANGPTL8 during the fed state as well, and importantly is associated with a decreased risk of type 2 diabetes. And then ApoC3 is unique in that it inhibits hepatic lipase as well, which has further TG effects. So the second key message that I want to make is that ANGPTL3, ANGPTL4, and ApoC3 are key regulators of lipoprotein lipase, and they're genetically validated targets for both triglyceride lowering and cardiovascular risk reduction. All right, so moving to the third and final portion then of the talk, I want to review the novel therapies for these targets and the clinical trial data to date in patients really across the spectrum of hypertriglyceridemia. You'll see most of these trials, they pick a population within hypertriglyceridemia to focus on. But before we get into therapies, I think it's very important to just emphasize the role that diet plays in managing these patients. As I mentioned with the case I presented at the beginning, currently available therapies aren't going to help triglycerides above 1,000, at least our old standard therapies. And so we really need to get triglycerides down with diet first. And the 2021 expert consensus decision pathway nicely lays out dietary recommendations for individuals depending on their TG level. And I actually print this out and share it with my patients who have TGs over 500. And you can see, for example, on the far right, TGs over 1,000, they need to eliminate added sugars. Total fat should be just 10 to 15% of their total calories, no alcohol. And so I think giving them a number, understanding what to shoot for is helpful. And diet is always first line with very high TG levels. Are currently available therapies, other than the new ones we'll talk about soon, statins, fibrates, omega-3 fatty acids, niacin, and even GLP-1s have some TG lowering effects. These can all be used. We have these in our repertoire. They're useful in lowering TGs, but ultimately the effect is pretty modest, up to 30% range, kind of topping out there. We don't have TG lowering therapies that can lower triglycerides above 50, 60% like we do for LDL. And so that's really been an unmet need that these new targets will hopefully surpass. And so again, here are those emerging targets: ANGPTL3 inhibitors, ANGPTL4, and ApoC3. Because these targets act as the brakes to lipoprotein lipase, which is good for TG clearance, if we can inhibit the inhibitor, or in other words, release the brakes, we de-repress lipoprotein lipase, and we allow for TG clearance to occur more rapidly and efficiently. So ANGPTL3 inhibitors, ANGPTL4 inhibitors, and ApoC3 inhibitors become exciting drug classes that I want to go through. And in each of these drug classes, we have different mechanisms of action. We have monoclonal antibodies, we have antisense oligonucleotides, and we have small interfering RNAs. And so here, I'm just going to summarize data from those that are furthest along in development, phase 2, phase 3, in some cases, approval. And we'll just march through these one target at a time, starting with ANGPTL3, which perhaps has the most drugs in this space. And we'll start off with the monoclonal antibody evinacumab. Evinacumab has a very robust triglyceride lowering, up to 70%, depending on the population being studied, but it also has, and this, there was a hint of this from the genetics, but an over 50% reduction in LDL cholesterol among those with high, persistently elevated LDL cholesterols. And for this reason, the drug ended up being approved for homozygous FH. It's a LDLR independent pathway. And so homozygous FH patients aren't often responding to our typical therapies like statins or PCSK9 inhibitors. So this has been a game changer for homozygous FH. And that's great. The downside is it's not available or approved for patients outside of homozygous FH, and it's very expensive. So heterozygous FH or severe hypertriglyceridemia, this is not an option. And so that opens the door for other ANGPTL3 therapies to possibly reach a broader audience. We had hoped that would be the case for vupanorsen, an antisense oligonucleotide against ANGPTL3. We did a multi-dose trial, phase 2b trial called the Translate trial, and we were able to inhibit ANGPTL3 up to 95% in the highest dose arm. And this translated to a 57% reduction in triglycerides, 66% reduction in VLDL cholesterol. However, this drug led to significant increases in hepatic fat fraction, such that the program was closed down, and this drug is not being pursued. So that's really left the door open for the siRNAs, and zodasiran is one that's probably furthest along in development, has had some phase 3 data. This is the ARCHES-2 trial published in the New England Journal of Medicine last year. Here you can see over 70% inhibition of ANGPTL3, which translates to over 60% reduction in triglyceride levels. So very exciting there. And then most recently this year, published in the Lancet was another siRNA against ANGPTL3, solbinsuran. And here, looking at multiple doses, we see up to a 52% reduction in triglycerides. So a couple of promising ANGPTL3 siRNAs that are continuing in clinical trials and may be able to have an impact more broadly for our hypertriglyceridemia and elevated hypercholesterolemia patients. So I'll move from perhaps the most crowded space to the target with really just one drug in active development, and that's MARS-001. MARS-001 is a monoclonal antibody against ANGPTL4, and they also just released new data, phase 2A data. The MAR-102 study was published in The Lancet and presented at EAS in May. And here you can see significant reductions in both triglycerides and remnant cholesterol at the higher doses, the 300 and 450 milligram dose, up to 53% lowering in both triglycerides and remnant cholesterol. So another exciting target here, and notably this, as seen in the genetics, not seeing significant reductions in LDL cholesterol. This is more of a pure triglycerides and remnant cholesterol lowering therapy and target. And so finally, then moving on to ApoC3, we have a few drugs and a bit of kind of history to discuss coming up to the recent most exciting news. But starting with volanesorsen, this was a prior generation antisense oligonucleotide against ApoC3. And it was tested in severe hypertriglyceridemia in patients with FCS. This is data from the COMPASS trial here, and a really robust 70% reduction in triglycerides. Because these patients started so high, this was an absolute reduction of 860 milligrams per deciliter for their triglyceride levels, huge reductions. And this actually led to approval in the EU for FCS under the name Waylivra. Volanesorsen, and this has been available for FCS. However, it was not approved in the US due to thrombocytopenia, which was seen in about 13%. And so this prompted a next generation ASO, specifically a GalNAc conjugated ASO, and that's olezarsen, which I think you've all heard about. A lot of big studies finishing the last couple of years, including an approval, which we'll talk about. This is the Bridge trial published that we led and published last year. This is a moderate HTG population testing the ASO olezarsen. And we tested two doses, a 50 and an 80 milligram, both reduced TGs by about 50%, but the higher dose a bit better at 53%. And importantly, these olezarsen also significantly reduced ApoB and non-HDL cholesterol, which are very strong markers for atherogenic risk. So not only is there an opportunity here to lower triglycerides, but also to lower cardiovascular risk with ApoC3 inhibition and olezarsen. There's also plozasiran, which is an siRNA against ApoC3. They also published last year their moderate HTG trial, the MIR trial. And the results were pretty similar to olezarsen. We see about a 56% reduction in triglycerides, a 13 and 18% reduction in ApoB and non-HDL cholesterol. So we appear to be seeing kind of a class effect for these ApoC3 inhibitors between olezarsen and plozasiran in the moderate HTG population. Well, what about ApoC3 inhibition for FCS, familial chylomicronemia syndrome, like the patient I presented? Well, two other major landmark trials published last year in New England Journal, the Balance trial and the Palisade trial, looking at olezarsen and plozasiran, respectively, in patients with FCS. And you can see here both demonstrated significant reductions in triglycerides, and that translated, most importantly, to a significant reduction in acute pancreatitis, 88% and 82% reduction in acute pancreatitis. This is really, I think, monumental results, and to see it with both drugs, very consistent messaging, and over 80% reduction in pancreatitis. There's been no drug or no prior therapy that can reduce acute pancreatitis in these FCS patients previously. So a landmark study, and ultimately that has now led to the first-in-class FDA approval, olezarsen, which is under the name Tryngolza for adults with FCS. And importantly, you don't need genetic testing to confirm this diagnosis and to get olezarsen approved. But filling out that FCS score and showing a clinical FCS is very much helpful. And then plozasiran should be up for FDA approval later this year as well for FCS. So to kind of summarize the three main targets here and all the drugs that we have in various stages of development, we have a few here in green that have been actually approved for rare diseases. We have one in red that is no longer moving forward due to side effects. And then we have four that are in late stage development with very exciting early data. And I know there are more therapies in earlier stages that aren't even included here that are yet to come. But I think the big picture here is that all of these drugs appear to achieve on the order of 50 to 70% reductions in triglycerides, depending on the dose and the population. And so this is much higher than what we currently have available in our toolbox for lowering TGs in patients. And so I think we're going to see a real shift in the landscape of how we manage these patients and what we use to do that. I'll just finish with a couple slides on exciting ongoing trials that I think are in important spaces. First is olezarsen in severe HTG. So I showed you the data for olezarsen in FCS patients, but what about those who have severe HTG, maybe even pancreatitis, but they don't have FCS? Should those patients, would they benefit from olezarsen? And so we're running the CORE and CORE2 TIMI 72A and B trials. We have enrolled over 1,000 patients with severe hypertriglyceridemia over 500, some of which have prior pancreatitis. And we're going to be looking at not only TG lowering, but we'll be looking at acute pancreatitis events, just like was done in BALANCE and PALISADE. And we also have a hepatic fat MRI sub-study where we're going to look to see if this drug can actually reduce hepatic fat. And there's some data from volanesorsen that may actually be the case. So it's an exciting study, and on clinicaltrials.gov, you can see that this study should be wrapping up this year. And then in terms of cardiovascular risk reduction, we have the first ever CVOT that's been announced in this space, and that is with plozasiran. It's the CAPITAN trial, cardiovascular outcomes trial, looking at plozasiran versus placebo among a mixed primary and secondary prevention population, looking at the endpoints of major adverse cardiovascular events. And so this should be getting up and running and will hopefully be the first of many cardiovascular outcomes trials in this space, especially given how strong the genetics looked for reducing coronary heart disease in these patients. I'll finish just with these take-home points to leave you with before we get into the Q&A here. First, I'd just say that hypertriglyceridemia exists across a broad spectrum with potential risks ranging from cardiovascular disease to acute pancreatitis. Second, ANGPTL3, ANGPTL4, and ApoC3 are all inhibitors of lipoprotein lipase, making them ideal targets to increase triglyceride clearance and lower TG levels. Third, genetically validated therapies targeting these key proteins are in late-stage development and in some cases approved for rare diseases. And then finally, ongoing trials are testing the efficacy of these agents on acute pancreatitis in non-FCS patients, looking at hepatic fat fraction, looking at plaque progression, and looking at cardiovascular outcomes. So with that, I thank you all for your attention and happy to spend the rest of the time taking questions.
Thank you, Nick. That was a great overview. I like the fact that there's hope on the way for our patients with hypertriglyceridemia. So one question in the chat, this is recorded and it will be available to you at lipid.org / practical pearls. And Nick, what we'll do, we have a bunch of questions, so we'll try to do quick answers. How can we measure LDL if triglycerides are high?
Yeah, right. So our typical kind of Friedwald equations, the calculated LDL breaks down when the TGs get to be, say, above 400. The Martin Hopkins can be better in this range, but really just direct measurements of LDL is probably the easiest thing to do. And some labs will kind of automatically do that when the TGs are very high.
Okay. Is there any trial where fibrates have improved cardiovascular outcomes?
Yes, it's kind of going back a ways. I think, if you look, but in the statin era, when with patients are on background statins, then I think not so much. So adding fibrates to statins, those trials have not been. But if you go back, 20, 30 years, there were some positive fibrate trials.
Okay, and just an FYI, the NLA clinical perspective on nutrition interventions for adults in dyslipidemia includes additional information about nutritional interventions for hypertriglyceridemia, including the table and adapted. So just go to lipid.org and look for the clinical perspective on nutrition in adults. Nick, which of the three targets, if inhibited, is most powerful in lowering triglycerides? So which is the
Yeah,
magic
it's
target?
that's a really good question. As I kind of made the point on one of the later slides, I think it's pretty consistent, and it's going to depend more on where the patient is starting. If they're starting at very high TG levels, that's when we're seeing more towards 70% reductions. If they're starting kind of more in the moderate TG range, it might be more like 50%. But all three really do appear. And again, these are multiple, a lot of these are phase two, multiple doses. So it kind of depends what dose you use and what population and baseline TG level. But I'd say for TG lowering, pretty similar across these. The LDL lowering is different. So ANGPTL3 has more of an LDL lowering effect, and we don't see that with the ANGPTL4. Really, I think when it comes to athero risk, we're looking at ApoB, and so ApoC3 also has an ApoB or non-HDL lowering effect on the order of 15 to 23%. So beyond TGs, there are some differences in LDL and ApoB lowering that I think will be important, as we think about outcomes trials.
So along those lines, just in a short sentence, how does Ang 3 inhibition reduce LDL?
That's a great question. I don't think it's uh, clearly known. I think it's a great question. Ultimately, with all of these, by activating lipoprotein lipase, you are creating more smaller dense particles like IDL and LDL, and so they then would need to be cleared. So you would also need to be increasing clearance of those LDL particles. So I think that's the most likely is, there's got to be because you're creating more LDL, there's got to be increased clearance, whether that's through LDL, probably through LDL receptor, but I don't think that's clearly known why the LDL lowering is so great with ANGPTL3 inhibitors.
Okay. So Carol Kirkpatrick has put in a variety of references for everybody in the Q&A section, so feel free to take advantage of that. Are there any planned cardiovascular outcome trials with any of the agents you spoke about today, whether it's ApoC3 inhibition, ANG3, or ANG4? Any outcome trials coming?
Yeah, so the Capitan trial there that I kind of put out at the last slide, so that question probably came in before. That's the first one to be publicly announced, which is very exciting, and hopefully there'll be more to come.
Okay. And here's a common presentation we all see. So in an uncontrolled diabetic presenting with, super high triglyceride levels, A1C greater than 10%, do you advise starting medications right away, or should we emphasize a tight glycemic control?
You cut out at the beginning.
All right.
How high were the TGs?
We don't have a low, 2 to 5 millimoles per liter. So it's a hypothetical with A1C greater than 10%, high trigs greater 2 to 5 millimoles per liter, and
Mhm.
you start with the medications or emphasize tight glycemic control.
Well, look, I mean, I think we all, when we're seeing patients, we aren't just treating one problem, right? We're thinking about multiple axes of risk. And even just within lipids, there's multiple axes of risk to consider. And then within metabolic health, there's multiple axes of risk. So I think we have to think about all of these. And as I mentioned in the slide about diet, I think first and foremost, when we're talking about high triglycerides, diet, if that's not optimized, there's a lot of improvements that could be made with diet and lifestyle. With diet, lifestyle, you can really get TGs could be lowered 20, 30, 40%. You can see big reductions that are just as strong or greater than our currently available therapies. So it's also going to have effect on the A1C. So, you kind of want to start there, and then if they still need therapy beyond that, then you can add therapy. The A1C, just note most of these trials excluded patients that had poorly controlled diabetes. So usually the A1C had to be, it couldn't be like 10 or something like that. That would have been an exclusion. So optimizing glycemic control is quite important.
Okay, great. I don't know if you want to take a stab here. Why were the strength trial and the prominent trial negative for CVD while reducer was positive?
Yeah, no, it's a great question, and I think that that's part of the reason. And I had those slides in that I took them out at the end there, but it's part of the reason why these therapies and targets are so exciting because I think TGs had just been a big triglycerides and cardiovascular events had been a big question mark. Reduce It was exciting at 25% relative risk reduction. Uh, with just 20% lowering triglycerides, roughly 20% lower reduction in triglycerides. And so that benefit, as we all have discussed at length, is far outweighed by the TG lowering that was seen. So there's other effects at play with the high dose purified EPA. There's clearly other benefits. Then you have the strength trial, similar, and pemafibrate trial, prominent. Both of those had TG lowering on the same kind of the same level, 20%, even 26%, I think it was with pemafibrate, and absolutely no change in cardiovascular events. So really, what I think a big driver is the ApoB reduction. So you've got to look at, are you lowering the overall atherogenic lipoprotein particles, ApoB? And in some of those trials, if you look, if ApoB is not changed or maybe it goes up a little, you're not going to see a reduction in cardiovascular events. So that's why when I showed like the ApoC3 data, for example, lowers triglycerides and it lowers ApoB and non-HDL. So those are the therapies that are going to be more likely to have a cardiovascular benefit.
Great. All right, here's a good clinical question, which we all face day to day. For patients presenting with triglyceride levels between 250 and 400 milligrams per deciliter, what are the recommended first-line treatment options? And what would be your expected reduction in triglyceride levels with standard therapy?
Yeah, yeah. Well, it's a good question. So if they have atherosclerotic cardiovascular disease or diabetes, these are going to be patients who should be on statin therapy. Their LDL should be optimized, and their triglycerides will improve with statin therapy as well, or at least decrease, may not normalize. So I think, statins in the high risk populations remains first line for these patients. And then with Reduce It, again, if they have ASCVD and or diabetes, Reduce It shows a significant reduction in cardiovascular events in this triglyceride range. So then that would be one to potentially consider adding on. But I think beyond that, pushing the TGs low without clear outcomes data is not helpful. But statins plus or minus icosapent ethyl in the ASCVD or diabetes populations makes sense.
Okay, great. And in your guesstimate, when do you think these medications will be available for us to treat our patients with elevated triglycerides?
Yeah, so I like using that triangle for the spectrum of HTG because it kind of shows how these are getting rolled out. So now we have the FCS trials published and one approval, the other one hopefully coming later this year. So FCS is kind of getting taken care of first. Then I showed you the core and core 2 trials in severe HTG, kind of the next big chunk. And that trial will hopefully be wrapping sometime this year. And then if that looks good, FDA approval, whatever, it takes 6 to 12 months. So maybe that's a year and a half away for severe HTG. And there the question is not just TG lowering, but also can we lower pancreatitis risk? And then for the moderate HTG, the bigger group, there it's going to take, I think, more time because to the point of the last question, do we even need to be treating these moderate TG patients? And to know, because they're not at risk for pancreatitis, so that's not a benefit to them. We need to be using these meds to reduce cardiovascular risk, and that requires the cardiovascular outcomes trials. So I think for these to be approved in moderate HTG patients, mild to moderate, we're going to need the outcomes trial data. And so those are going to be, years away as we really just have kind of one announced and starting up so far.
Right. So I guess that means for the rest of us, we're talking about fibrates, uh, icosapent ethyl, and we're talking about statins.
Yep.
Okay. Is there any use for niacin in patients with high triglycerides at this point?
It's still an option, but if you look, like, for example, at that expert consensus statement or the European triglyceride guidelines, it's really more about fibrates and prescription grade omega-3 fatty acids. Niacin is not kind of in the algorithms for that. It's still something that can be used. I don't use it a lot. There are side effects, but that's kind of where we stand with niacin.
All right. There was a question here about, I guess, using different scoring systems in our last minute versus the Moulin scoring system versus the NAFCS. Should we use both? Should one replace the other? Just in a quick answer.
Yeah, I think either is fine. I think you want to go through the work of counting it up, because if you can give a patient clinical FCS, that could be the difference in getting them on olezarsen and preventing pancreatitis. So either score should be fine, and then you kind of document that in your note and in the order when you're getting the therapy.
Great. All right. So I think it was a great presentation. Everybody is excited to learn so much about triglycerides. Again, this will be available for you at lipid.org. Some of the references regarding diet and dyslipidemia statements and recommendations are at the NLA website. And if you have any questions, you can always reach Nick or myself. So I want to thank everyone for tuning in this afternoon. Nick, thanks for taking time out to do this. Everybody have a great week and a great weekend. Thank you so much.
Thanks, everyone.